So those of you who give talks, I don't know if this has ever happened to you, when you go into your file and you pull out your talk and it's not there. That just happened to me. It's happened once or twice before, and the other times I ended up giving a better talk than I did with the script. So let's just hope that happens now. I just arrived yesterday from Berlin, actually to discuss the Joint Learning Initiative. I had two files, one Germany, one Seattle. And I brought the Seattle file, but the speech was in the German file. A number of years ago, I had a proposal that came from the founding of the O'Neill Institute for Framework Convention on Global Health. And many of advocates in civil society warmed to it, and it was discussed by a number of countries. There was the Norwegian Ministers of Health and Foreign Policy held an international meeting in Norway around the Framework Convention on Global Health Approach, and particularly guided by the Oslo 7, which was mentioned, a group of 7 countries on health and foreign policy. Kelly mentioned them. Recommended that that governments would be scared by a treaty. And so instead what we should do is have a joint learning initiative on national and global responsibilities for health. And we have launched that next month in October. An editorial will come out on the Joint Learning Initiative in the World Health Organization Bulletin, and it will be a major paper in the World Health Report of 2011. And so even though I don't have my speech, if any of you would like more information about the Joint Learning Initiative, just email me, gostin@law.georgetown.edu, and I'll be happy to get all of the information to you. The Joint Learning Initiative has 4 interrelated systematic ways of viewing global health, which we believe address the 4 major questions that advance our field collectively. One of them is, what is the core package of essential health goods and services that every human being has a right to as a matter of the right to health? Secondly, what every state owes to its own inhabitants in terms of guaranteeing and ensuring the right to health. Thirdly, what do high-income countries have and owe to build capacity in low and middle-income countries for the right to health? And then finally, what kind of global health architecture is needed to ensure that all countries live up to their responsibilities to ensure health for all the world's population? We believe these to be critical, and we are launching the Joint Learning Initiative as a bottom-up, stakeholder-driven initiative to address these questions over the next number of years. Now, so why do we want to do this? We've been talking throughout this meeting, and I thought Peter's discussion really epitomized it, of all of the critical global health challenges. We've talked about child and maternal health, HIV/AIDS, tuberculosis, malaria, under 5 child mortality, and injuries, and of course non-communicable diseases. By 2020, 70% of all deaths in low and income countries will be non-communicable diseases. And for only the 2nd time in the history of the United Nations, it's going to hold a high-level summit on a health issue. The first one was on AIDS, and it transformed our world of global health. The next one in 2011 will be on non-communicable diseases. And one of the goals that we have for the NCD Alliance is to include NCDs in the Millennium Development Goals, which I think was a critical omission in those goals. So let me just go through as quickly as I can these four components of the Joint Learning Initiative. The first is, what is the core package of essential health goods and services that every individual has the right to expect? Without understanding what this package is, it's impossible to determine what states' obligations are to their own inhabitants and also what the international community's responsibilities are. These include what the WHO calls the health services building blocks, workforce, data systems, laboratory systems, and the like. Secondly, essential vaccines and medicines. And thirdly, something that I've called basic survival needs, but one could call them many other things. And I'm relatively new to the world of global health, but I've been steeped in public health for a long time. I think Jim Curran is here, and he would, I think, relate to this. But I often go to global health meetings, particularly diplomat meetings, about Foreign Assistance Act and things. And I come out thinking, I don't even know what they've been talking about. And it's certainly not a population-based approach to health. What we've learned is that in order to improve the health of the population, one thing before all the other things are fundamental, and we barely discuss them. These are what we might call basic survival needs. They're sanitation and hygiene, and sewage, vector control, nutrition, clean water, tobacco control. These are the kinds of things that every human being needs as a standard environment for health. And one can put this very simply. Everywhere in the world, if you turn on your tap, clean water should come out. When you're hungry and you go to the table, there should be balanced nutritional food on the table. That you shouldn't be plagued with rats or mosquitoes that bear diseases. That there shouldn't be ubiquitous marketing of tobacco products and the like. The second part of the Joint Learning Initiative is what every state owes to its own inhabitants. I made the mistake when I first came to global health, and I think many of us do, to actually skip what's most important. We always go straight to what the international community owes, what the Gates Foundation owes, what the US or DFID owes to the world's poor. But one needs to start with what every state owes for its own citizens. And if one takes international law seriously, and particularly the human right to health and the general comment on the right to health, a state's responsibilities to its own citizens must be primary. And just to give you an example, African heads of states more than 5 years ago determined that they would give 15% of their budgets to the health sector, but many years later it is still only 9%. The WHO estimates that it would cost about $40 per person per year for a basic package of health services. This is a way underestimate, and it doesn't include basic survival needs. But if you look in sub-Saharan Africa, the average is under that bare minimum, and some states provide much, much less per capita, which certainly cannot meet the right to health. States also owe, not just low and middle income, but high income states owe a responsibility of good governance, transparency, accountability, and the full engagement of civil society and stakeholders in health decisions. The third is what high-income countries owe to build capacity in low-income countries. Here, we believe that the concept of aid is wrong. Aid assumes that you have a benefactor and a dependent, and it is a matter of charity rather than a matter of mutual security and international law and global social justice. As a result of this being aid, there are many pathologies that arise from that. Not only the donor-donee relationship, or the fact that there's been some good data to suggest that for every dollar in international development assistance for health, nearly a dollar is removed from the local domestic budget for health. But much more than that, a state cannot accept ownership and take command of their own health policy so long as there is aid. Because what aid does is it means that the donor can decide when to give, how much to give, to whom to give, and for what purposes. That's led by the donor rather than led by the country. The country needs to have sustainable, scalable, predictable levels of support, and looking at the international community's obligations as a matter of global justice and international law rather than a charitable contribution is important. Just to give you, for example, even though over the last decade, international development assistance for health has quadrupled, still high-income countries have not even come close to the 0.7% of their GNP that they promised in 1970. Fourth is what global health architecture is needed to ensure that all states and stakeholders and their partners live up to their responsibilities. I don't have a lot of time to go into this, but I've done a lot of work on the concept of global health governance challenges. These include challenges of leadership, particularly the World Health Organization, which is, I think, a wonderful technical organization, but has never really lived up to its normative leadership role that it would need. Secondly, there are skewed priorities. Again, one of Peter's slides showed you about the funding compared to the burden of disease. If you actually look at WHO funding itself, particularly its external budget given, it's skewed even more than the what you showed. And particularly if one looks at this basic survival needs or a population-based approach to global health, where pitiful NCDs, injuries, mental health all suffer badly. Coordination is a very important point. We've noticed throughout these 2 days that there's one after another person coming from the first world talking about how their program is really, really good. But if you're from the point of view of any individual country, there could be hundreds or thousands of these. You're constantly writing grants. That's why we need to give them technical assistance to write grants. They're reporting to multiple things. So we invited a number of people, African health ministers, to Oxford without DFID, without USAID, without the Gates Foundation there, and they were in despair because of all that they just didn't feel like they knew what was going on in their country. Very often NGOs compete with themselves, but they also compete with the country itself. So if you have a very fancy PEPFAR or Global Fund clinic, and right next door there's a Ministry of Health primary care or maternal child health clinic, they can't provide the same resources, staffing. They can't give their staff the kinds of opportunities, economic and others, that the external group can do. So global health governance is an extremely important part of what we need to do. The Joint Learning Initiative is going to be a bottom-up process. We've been, and it will be South-led. We're gearing up to large stakeholder meetings in sub-Saharan Africa and Latin America and perhaps China to try to build support for these four ambitious targets. So thank you. Sorry I didn't have my speech and hope it worked out.